Good evening to everyone and welcome to today's session. Today we have four interesting topics: diabetic retinopathy, retinoblastoma, myopia and trachoma. So these are the major things that we are going to take up today. We invite our online classmates Dr. Manu, Neena, Sarvodaya, Kavi, Rohit, Murali, etc., etc. And also the students from Tirupati, Guntur, Kurnool and Visakhapatnam. So, diabetic retinopathy. What is the most important risk factor that the people go into retinopathy? It is the duration of the diabetes. There is a time bomb which will be ticking from the point of diagnosis of the diabetes. So, 50% of diabetic retinopathy will develop after 10 years. 70% will develop after 20 years. 90% will develop after 30 years after the onset of the disease. It's more common in the females than in the males. And if you compare the duration versus a poor metabolic control, between the two, which is much more important, always the duration. Even if you tightly control metabolically, if 30 years have passed, then some amount of retinopathy is invariably present in the people. So that is the reason poor metabolic control is less important, but yes, poor metabolic control can be a predisposing risk factor for the progression. There is no doubt. Then how about heredity? It is being transmitted like a recessive trait without sex linkage. That's how we describe the hereditary influence. In fact, what are the major divisions of the diabetic retinopathy? Background retinopathy, non-proliferative, and neovascularization case are proliferative retinopathy. The effect of the heredity is more on the proliferative retinopathy, is what we need to appreciate. Similarly, pregnancy can hasten the diabetic retinopathy and can worsen the retinopathy. Pregnancy is a risk factor. Similarly, hypertension concomitantly if it is present. Smoking, obesity and hyperlipidemia, they are all the other risk factors. So what is diabetic retinopathy? It is a microangiopathy involving the precapillary arterioles and capillaries and venules. Broadly, diabetic complications had been divided into macro and microvascular. You all know very well. Now, if you look at the various vascular changes in diabetes, there is a thickening of the capillary basement membrane, endothelial cell damage, increased stickiness of the platelets, and ultimately there is a microvascular occlusion which will lead to retinal ischemia. The moment retina goes into ischemia, there will be a lot of vascular endothelial growth factors become released. Any retinal ischemia and hypoxia is a stimulation for the retinal neovascularization. So that is the reason retinal ischemia will lead to, in turn, capillary leakage, microaneurysms, hemorrhages, retinal edema, hard exudates, AV shunts, and the development of the arteriovenous shunts will lead to what is called IRMA. What is IRMA, doctor? Intraretinal microvascular abnormalities of the diabetes. And ultimately there is a development of neovascularization. That's how the progression of the diabetic retinopathy goes on. Now, doctor, what is the general classification? There is a non-proliferative diabetic retinopathy, which is in turn divided into mild, moderate, severe, very severe. Then we have a proliferative diabetic retinopathy, diabetic maculopathy, and advanced diabetic eye disease is the broad division of the diabetic retinopathy. Now, 2-3 points about each of them are very important. Non-proliferative diabetic retinopathy. So you are the house surgeon in charge of your elderly patient Somaya, who has come to you in an optal posting to get his eye checked because his daughter's marriage is coming up. So he wants to see the marriage a little better. So how do you identify non-proliferative diabetic retinopathy? We find microaneurysms in the macular area, which is the earliest detectable change. This is another important frequently asked MCQ. What is the earliest detectable non-proliferative diabetic retinopathy change? What is your answer like a parrot? Microaneurysms. There can be retinal hemorrhages which can be deep. If they are deep, they will be dot and blotch. And they can be superficial. If they are superficial, the hemorrhage will be in the direction of the nerve fiber distribution. Hence, it will be flame shaped. Flame shaped are superficial, dot blot are deep, is what you need to remember. So this is what we are talking about. Microaneurysms, which are located in the inner nuclear layer of the retina. These are the things, if you find, it is the first clinically detectable lesion in the case of the diabetic retinopathy. Then, if you look at the hemorrhages, as what you can see, they can be superficial, which are flame shaped, and deep, which can be dot and blotch. Then there can be hard exudates which can develop, and retinal edema because of the increased capillary permeability also can develop. Now, what are hard exudates? Hard exudates are those yellowish, white, waxy looking patches. They can be in the form of clumps, or they can organize themselves into a sarcinate pattern, or the different ways. It is the macular area which decides the central vision, is the place where commonly hard exudates are found. Now, a few comments on retinal edema. Because of the retinal edema, there is a thickening of the retina. Now, do you find cotton wool spots in diabetic retinopathy? Cotton wool spots are found in a lot of situations other than diabetic retinopathy also. So, what is the significance of finding cotton wool spots in diabetic retinopathy? If there are more than 8 cotton wool spots, it's a very high risk that this case of non-proliferative diabetic retinopathy in no time is going to progress into proliferative diabetic retinopathy. That is a important indication. Their number will decide the risk of progression. Then there can be venous abnormalities, like the retinal veins can show beading, looping, dilatation, etc., etc. Then IRMA will develop, which is intraretinal microvascular abnormalities in the non-proliferative diabetic retinopathy. Then there can be dark blot hemorrhages which represent hemorrhagic retinal infarcts, which are deeper level of hemorrhages, is what you typically come across. Now, once more, this is an example of what we are expected to see as a house surgeon when we peep into the fundus of a diabetic patient. Microaneurysms prominent in the macular area are the earliest detectable diabetic retinopathy lesions. Then these are the typical flame-shaped hemorrhages, which are the superficial hemorrhages. These are the hard exudates, how they basically look like. They can be clumps or they can be a sarcinate pattern, as what you are able to see. Then this is the retinal edema, which you are able to see here, and cotton wool spots. If these cotton wool spots are more than 8, the chances of progression is very high. And these are fundamentally intraretinal microvascular abnormalities, which include dark blot hemorrhages, hemorrhagic retinal infarcts, sarcinate retinopathy, etc., etc. Now, doctor, proliferative retinopathy. What are the 5 to 6 important points that you need to know? After 25 years of marriage with diabetes, so diabetes is like the second spouse for the patient. Hypertension is the third spouse. So we are all polyandrous and gamous because of the multitude of diseases after 40. After finishing silver jubilee, with diabetes. 50% will have proliferative diabetic retinopathy. Generally, it is more common to see such long-standing diabetes in type 1 diabetes. That's the reason proliferative diabetic retinopathy is more often seen in the type 1 diabetic individuals who finish at 25 years. Generally, when will type 1 diabetes will begin, doctor? The moment the individual enters into puberty, that is the time. That is the time. Very good. So, Nina is adding up what are the other scenarios where we find cotton wool spots. So, hypertensive retinopathy, collagen vascular diseases, etc., etc. Very good. So, one more thing I thought of telling you is, see, every day we raising a quiz में मजा नहीं है. आप तो कैसे भी आंसर कर रहे हैं क्विज को. You can raise one question and type it into the chat window, your own question, and give an opportunity whether other classmates and including your teacher, can he answer or not. So we will also guess. When we guess, some of us will go wrong, then you can reveal your right answer. And always remember, while you are reading, the questions that you frame are the ones which are going to come in exam. That's a very common. So while reading only, you must develop some that intuitional habit. Probably this can become a question, if so, etc., etc. So let us start it from tomorrow onwards. You also prepare some questions and then shoot us. Now, neovascularization is the hallmark of proliferative diabetic retinopathy. It is of two subtypes. Neovascularization occurring closer to the optic disc, neovascularization occurring everywhere. NVD, NVE is what we divide. Typically, it occurs along the major temporal retinal vessels, the neovascularization. And the neovascularized vessels in the retina can form vascular fronts. And later on, there can be condensation of the fibrous tissue around these vessels. And that can lead to fibrovascular epiretinal membranes around this neovascularized new vessels. And ultimately, when this fibrovascular epiretinal membrane forms, which is very fibrous, it will have a dragging effect on the vitreous, and that lead to vitreous detachment, vitreous hemorrhage, etc., etc. Now, what are the various types of proliferative diabetic retinopathy? But before that, this is what you need to know. In a diabetic patient, there can be black floaters which can occur whenever there is a development of what you are seeing here, vitreous hemorrhage is the ultimate consequence of the diabetic retinopathy. Now, there was a very famous study which was done called diabetic retinopathy study. According to this study, the proliferative diabetic retinopathy is further classified into few subtypes. Proliferative diabetic retinopathy without high risk characteristics, it's called early PDR. Proliferative diabetic retinopathy with high risk characters, where it is called advanced. Now comes, what are those high risk characters in case of proliferative diabetic retinopathy? How will you characterize of a high risk in a given situation? When the neovascularization typically develops 1/4 to 1/3 of the disc area, with or without vitreous hemorrhages or pre-retinal hemorrhage, then you call high risk. If the neovascularization near optic disc develops less than 1/4 of the disc area along with the vitreous hemorrhage, then you basically also call high risk. If there is a neovascularization anywhere other than the disc, if it is more than half the disc area with vitreous hemorrhage, is also another important high risk factor. Most of the times if questions come on microaneurysms, dot blood hemorrhages, flame shaped hemorrhages, everyone will answer. When will you call tough paper this entrance? Suddenly if he raises a point about high risk factors, criteria, etc., it becomes difficult. But this was never asked in the previous exams. I still incorporated in our discussion because this has a potential of becoming an MCQ in the future. Because undergraduate level may this much of gyan about diabetic retinopathy subclassification is very unexpected of. Now, but diabetic retinopathy study was a previous MCQ. You know what the MCQ was on? What does the acronym DRS stands for? It was a simple question. But if he asked acronym means he can also ask something below the paragraphs also. So you must be quite sure. Now doctor, diabetic maculopathy is a very important entity. Why we are worried about the macular edema? We are worried because macular area decides our central vision. If the central vision is affected, there is no use. That's the reason we are very much worried. In which situation do you see macular edema? Both the non-proliferative, proliferative. In either of them you can see the macular edema is what you need to basically remember. Why does macular edema occur? Once more, it is the increased permeability of the capillaries, retinal capillaries, which is the underlying cause. So this is the typical fundus appearance of how a macular edema typically looks like. Now, when do you call it as a clinically significant macular edema is an important issue. For that you need to do slit lamp examination, and there are certain criteria to call it as clinically significant macular edema. Very simple. If there is a thickening of the retina, if there are hard exudates, if there is a zone of retinal thickening, one disc diameter or larger in size, at least a part of which is within one disc diameter of the foveal center. Fovea is the area where highest level of visual acuity is there. Then you basically call it as clinically significant macular edema. Maybe you can take one pen and cut it down in the notes. Examiner may not ask criteria for the clinically significant macular edema at MBBS level, but we don't know. This is not a very standard MCQ, but still. Now doctor, what is an advanced diabetic eye disease? Vitreous hemorrhage, if any of this develop, you call it as advanced diabetic eye disease if complications develop, which include a vitreous hemorrhage, retinal detachment, neovascular glaucoma, etc., etc. Now, how do you want to manage a case of diabetic retinopathy? Screening is very important. Preventive measures are very important. Suppose if there is no diabetic retinopathy or only a mild non-proliferative diabetic retinopathy, such guys require every year. Moderate every 6 months, severe every 3 months. Already proliferative diabetic retinopathy developed, but there are no high risk characters, then every 2 months. This is the favorite MCQ of the examiner. A good number of times this comes as a question, and it will be sickeningly sad situation if we can't answer, because we know screening is done, but based on the type of the underlying problem, how frequently screening should be done also, you need to be very clear. And these are all very important. Why? Because diabetes, hypertension, diabetic retinopathy, our own grandmother will be unhappy if we don't know this, because she will say, what is the use of your not deciding when I should go to an ophthalmologist? Now, how do you treat, doctor? Lipid control, glucose control, BP control, all that we have parroted out in general medicine. But what we need to know something else in ophthalmology is Any role for pharmacological modulation? Yes, sir. Protein kinase C inhibitors, vascular endothelial growth factor inhibitors, aldose reductase inhibitors, ACE inhibitors, antioxidants like vitamin E, they have a role in diabetic retinopathy, especially vascular endothelial growth factor inhibitors is one of the previous MCQ you need to be very sure about. Is there any role for the intravitreal steroids? We can give fluocinolone acetonide or triamcinolone in order to manage a diabetic macular edema, basically. Now comes a very important area on which a lot of questions are asked both previously and in future. Photocoagulation, role of it in the case of the diabetic retinopathy. The main treatment of retinopathy, maculopathy is photocoagulation. We can use either argon or diode laser. This is also another common question. Which type of laser do we use? Now let us talk about photocoagulation of the macular edema. Only if there is a clinically significant macular edema, then only we will do the photocoagulation. That's the reason we need to know what are the criteria based on which we call it as clinically significant macular edema. If the ischemic lesions already have developed, ischemic lesions, that becomes a contraindication for doing the laser treatment. After all, by using laser, we are burning and creating ischemic areas. I mean, we are burning out those areas which are a focus of neovascularization. Now, if a patient has got a proliferative diabetic retinopathy associated with clinically significant macular edema, what do you want to do? Because for proliferative diabetic retinopathy, what you need to do? Pan-retinal photocoagulation you need to do. And for a clinically significant macular edema, what you need to do? Macular photocoagulation you need to do. Between the two, which one you want to do first? Typically, we need to do macular photocoagulation. It need to be considered first before going for pan-retinal photocoagulation, because the pan-retinal photocoagulation will worsen if you apply it in a patient who already has got significant macular edema. Because if you do pan-retinal photocoagulation, macular edema can worsen. So first to treat that. Hence try first to do macular photocoagulation, then pan-retinal. This is the order which you need to remember, one of the questions of the examiner. Now, how will you carry out macular photocoagulation, doctor? We have two techniques. One is called focal treatment. Focal means what will you do? Argon laser you will take. The microaneurysm, IRMA, short capillary segments, all these things are fundamentally treated with this focal treatment. We use 100 to 200 micrometers of 0.1 second duration is the prescription of the focal treatment. Then we can also apply grid pattern of laser. Burns can also be applied in the macular area. Suppose if they develop a diffuse macular edema, then we need to use a grid treatment. So that's all the story. But mainly you need to know, macular photocoagulation should precede pan-retinal photocoagulation. That's the whole idea. And patient should have clinically significant macular edema for you to do macular photocoagulation. Then doctor, pan-retinal photocoagulation. In this, what are we doing basically? We are applying 1200 to 1600 burn spots, each 500 micrometers in size and 0.1 second duration, and these burns are applied around 2 to 3 disc areas away from the center of the macula, extending peripherally. And which is the area which is first coagulated is an important MCQ. It is the temporal quadrant of the retina which is first coagulated. So what is the role of pan-retinal photocoagulation? It will destroy that ischemic retina, which is the one which is producing lot of vasogenic factors like vascular endothelial growth factor, etc., which is leading to neovascularization. We wanted to get rid of all those fellows who are the whistleblowers. Like the ischemic retina is basically destroyed by doing pan-retinal photocoagulation. Now comes one of the favorite MCQs of the examiner. What are the indications of the pan-retinal photocoagulation? 1, 2, 3, 4, 5, you must be able to tell. So, if there is a proliferative diabetic retinopathy with high risk progression criteria, yes, indication for PRP. If iris area mein neovascularization is there, what is that called? Rubeosis iridis, indication for PRP. Then severe non-proliferative diabetic retinopathy also we will do. We have divided non-proliferative diabetic retinopathy into early, moderate, severe, very severe. Severe non-proliferative diabetic retinopathy, where patient has a poor compliance for the follow-up, or if he is undergoing cataract surgery or AG capsulotomy. Then if there is a renal failure, if he is only having one eye, he is a high risk guy, and pregnancy. In these people, even if it is in a non-proliferative stage also, we go ahead with doing the pan-retinal photocoagulation. This is one of the favorite MCQs, any exam you need to know before you go. Then this is an example of rubeosis iridis, neovascularization of the iris which we are talking about. What are all the conditions which can lead to it, doctor, other than proliferative diabetic retinopathy? Central retinal vein occlusion and proliferative diabetic retinopathy are the main causes for rubeosis iridis. It can also occur with uveitis, cravo, but CR vivo it is more common. So cravo, CR vivo are another very, very high yield topics in ophthalmology which we need to master. Intraocular tumors, etc., etc. Now, any role for surgical management of proliferative diabetic retinopathy? Yes, sir. Pars plana vitrectomy is typically indicated because proliferative diabetic retinopathy is leading to vitreous hemorrhages, fractional retinal detachment, etc. No? So, if there is any persistent vitreous hemorrhage, any tractional retinal detachment, if there are any epiretinal membranes developed, that becomes an indication for doing pars plana vitrectomy in a case of diabetic retinopathy. So this is an example of how a patient has developed a tractional retinal detachment presenting with photopsia and floaters, and he need to basically receive pars planectomy. That's all the story you need to know about diabetic retinopathy. Then who is the twin sister of diabetic retinopathy? Hypertensive retinopathy. Only one thing you need to know for entrance exam. What is the Keith Wagner's classification? 1939 when he classified, nobody could beat him till now. It is a very good way of classifying even today in 2013. So doctor, grade 1 means what? There is a generalized arteriolar attenuation, particularly small branches of the retinal arteries, they will be attenuated. Accentuated means prominent, attenuated is loss of prominence. Then there is a broadening of the arteriolar light reflex and the concealment of the vein. This is called grade 1. What do you mean by grade 2? Narrowing and attenuation of the arterioles. Along with that, at the arteriovenous crossings, the veins will be showing a deflection, which is called as Salus sign, is basically grade 2. Then what is grade 3? Lot of things are included in grade 3. copper wiring. Then the banking of the veins distal to the AV crossings called bonnet sign. Tapering of the veins on either side of the crossing is called gun sign. Right angle deflection of the veins is also Salus sign. Then flame-shaped hemorrhages, cotton wool spots, hard exudates are all grade 3. Grade 4 means all grade 3 changes. Along with that, silver lining is grade 4 and papilledema also is grade 4. Lot of times questions come on copper wiring versus silver wiring. You are not going to forget. Copper is 3. Silver is 4. Is what you should not fundamentally forget. Now let us quickly see few classical features of the grading. So what you are seeing here is there is a moderate narrowing is of the vessel is what you are seeing, which comes under grade 1, attenuation. Then this is an example of grade 2. Grade 2, you can focus on this arrow, where there is a marked narrowing of the retinal arterioles with the exaggeration of the light reflex and changes at the AV crossings. Then why you like to call this grade 4? Because of the presence of the papilledema, you call it as grade 4. Then these are the typical cotton wool spots. Where do you see cotton wool spots, doc? Hypertensive retinopathy, diabetic retinopathy, toxemic retinopathy, HIV, collagen vascular disease, etc. Then one more commonly asked question is CMV retinitis. We are all living in era of HIV. So, what is the classical thing about CMV retinitis? It is typically called pizza pie retinopathy. It looks like pizza. Some hungry ophthalmologist whose wife was not feeding him might have named it. So, pizza pie retinopathy in case of CMV retinitis. So that is, there are the few things about hypertensive retinopathy. Keith Wagner's classification, you should not forget. Okay, doc. Now, in hypertensive retinopathy, there are certain changes which occur because of arteriosclerosis. So what are those changes? That AV nipping and changes of the arteriolar reflex are there, no? Those changes are due to arteriosclerotic changes. And presence of these AV nipping and arterial reflex changes, they are indicators of the duration of hypertension. Longer it is, the greater chances of finding arteriosclerotic changes. Then the hemorrhages, exudates and retinal edema you have seen, no? They are the consequence of which pathophysiological mechanism of hypertension? They are due to the increased vascular permeability in hypertensive retinopathy. So, vasoconstriction, increased vascular permeability, arteriosclerosis. These are the three major features in the fundus picture of hypertensive retinopathy. So, what changes reflect vasoconstriction? Arteriolar narrowing, cotton wool spots, etc. Flame-shaped hemorrhages, hard exudates are the markers of the leakage. And the presence of changes in the AV crossings and the reflex changes with the thickening of the arteriolar wall are the features of arteriosclerosis. And the macular star, this is called as macular star. Macular star is the swelling, it is typically seen with the hard exudates in the Henel's area layer. It is a marker of increased permeability. So these three are the important pathophysiological mechanisms.